Assalamu alaikum. I am Dr. Naeem. I am an assistant professor in the Department of Surgery, Ward 2. I welcome you all in the sixth endocrine week of sixth annual endocrine week. Today we have changed the order of our program. Besides starting the inaugural session, we will start with the lecture from Dr. Keepal, and after that we will start our inaugural session. So I request Dr. Keepal to please come and deliver his talk on an approach to a solitary thyroid nodule.
Excellent. Thank you very much. I want to especially thank Shamim Qureshi and the whole group here for inviting me to come here and speak and spend the whole week in Karachi. So far it's been fantastic. The food has been delicious. The hospitality has been amazing. Truly enjoying my visit and looking forward to the entire week. The first talk is going to be a management of thyroid nodules, and I kept it somewhat basic, and I'm going to go through my philosophy on how to manage thyroid nodules and what I do and what I think of when I see a patient with thyroid nodule. So this slide, I always like to use this slide when I start my talks, and I like to think of the management of thyroid nodules in three distinct phases. So there was the age of palpation. This was back, 50 years ago, 40 years ago, 30 years ago, when patients came to us because they felt a nodule, their doctor felt a nodule, somebody noticed a nodule, and that was how these patients presented. This is a different population of patients, at least in what we see in the United States right now, because in the United States, we see the age of detection. Majority of our thyroid nodules are found not because the patient felt something or the doctor felt something. It's because the patient had a scan for some other reason. Maybe it was a carotid duplex scan and they noticed a thyroid nodule. Maybe it was a CAT scan of the brain or an MRI scan of the spine or something else, and they found an incidental thyroid nodule. And that's kind of the disease that we are managing now in this day and age. And I'm hoping that we hopefully end up into the age of reason, because right now the management of the age of detection is not easy. We're seeing hundreds and hundreds of thyroid nodules a month, and sometimes we're not really sure how to manage them or what to do. So we're going to talk a little bit about the age of reason. So my talk today is broken up into several categories. First, we'll talk a little bit about the brief review of thyroid nodule, and again, just very simple cancer management. I'll be able to multiple talks on cancer management during the week. I'll talk a little bit about the FNA cytology. What does that mean? How do we interpret it? The implications of the indeterminate cytopathology, because that is always the one that's a little bit confusing. I'll talk a little bit about molecular markers and molecular profiling, because we're using a lot of that right now in the United States, so I think it's good to at least understand the concepts behind molecular diagnostic tests. And then we'll talk, I have one last interesting case presentation at the end, so hopefully we'll get to the case. It'll be hopefully interactive. So this is still a problem after 50 years. This was published in 1964 in the New England Journal of Medicine. How to select a patient with a thyroid gland, a nodular thyroid gland in whom there is the greatest likelihood of finding a cancer, even back then, was a subject of considerable disagreement in 1964. And it's still a subject of considerable disagreement in 2019. So thyroid nodules are very common. We are all aware of these data. This is nothing new. In the United States, over 100 million patients will have thyroid nodules. 40 to 50% of the entire population by the age of 60. If you do sonograms on everybody, you will find some form of a thyroid nodule or an autopsy. But fewer than 10% of those are actually palpable nodules, right? So majority of these nodules are detected nodules on imaging studies. The good news, however, even though we have so many thyroid nodules, thyroid cancer is still very uncommon. Right, only 5 to 15% of medically evaluated thyroid nodules will be positive for malignancy. In 2018, there were approximately 75,000 new cases of thyroid cancer, but once again, the mortality rate is very, very low. These patients do really well. The mortality rate still remains around 2,000. And we are all very familiar with this graph, the thyroid cancer incidence. And, I think we've all seen different forms of this particular graph. The incidence of thyroid cancer has increased dramatically from the